Hi, my name is Madison Tackett, a fourth-year medical student from the Kentucky College of Osteopathic Medicine. The title of my presentation is Going Mono a Mono with TNF-alpha inhibitors. This is a case of EBV reactivation in a 66-year-old female on adalimumab for ulcerative colitis. A 66-year-old female with a past medical history significant for ulcerative colitis on adalimumab injections presented with fatigue, fevers, chills, and night sweats and worsening confusion of 4 weeks duration. She was admitted to the hospital with fever and toxic metabolic encephalopathy in the setting of immunosuppression. She was currently receiving adalimumab injections every 2 weeks, and her most recent injection was 2 weeks prior to presentation. On examination, she was febrile with a temperature of 101.3. She was tachycardic and tachypnic. She appeared very ill, somnolent. She was difficult to arouse and diaphoretic. Examination was also concerning for diffuse, non-tender cervical lymphadenopathy. Laboratory studies revealed a mild anemia, elevated EBV viral capsid, nuclear antigen, and early antigen IgG. Understanding EBV serology is crucial in diagnosing active versus latent versus reactivated EBV. Viral capsid IgM is the first to appear in the acute phase and will change to IgG 2 to 4 weeks later. Viral capsid IgG remains positive throughout life. Nuclear antigen or EBNA IgG appears 3 to 6 months later and is only positive in latent or reactivated EBV. Early antigen IgG is only produced during lytic phase of viral replication and can only be detected in active or reactivated infection. In our patient, viral capsid, EBNA, and early antigen IgG were all elevated, consistent with reactivated EBV. For our patient, her adalimumab was discontinued promptly upon admission to the hospital. Following supportive care, her symptoms improved and she was no longer febrile. Diagnosis of reactivated EBV was made. Her adalimumab was held at discharge and ultimately resumed 4 weeks later at an outpatient follow-up after repeat serology showed improvement in viral activity. In conclusion, immunosuppressed patients presenting with encephalopathy and fever should be evaluated broadly for infection. Hold TNF-alpha inhibitors during acute infections. Signs and symptoms of EBV include fever, fatigue, malaise, tonsillitis or pharyngitis, lymphadenopathy, and hepatosplenomegaly. EBV reactivation serology includes elevated VCA, EBNA, and early antigen IgG. Clinicians must be familiar with common and lesser-known adverse reactions of these medications as they become more widely used. The relationship between these more common viral pathogens and reactivation in TNF-alpha inhibitors must continue to be investigated. This case report is one of very few to suggest this relationship between TNF-alpha inhibition and EBV reactivation.